It's a pleasure to be here in Vicenda. Thank you very much for the invitation. During the next 20-30 minutes, I'm going to talk about CRRT modalities. And these are my conflicts of interest. So first of all, I would like to, if I may, give two friendly advices regarding renal replacement therapy modalities. The first one is that please use the correct abbreviations. I don't know about you in your units, but in my unit, for example, I have a lot of students, a lot of fellows, and sometimes also some attendings. They really do not use the correct abbreviations, and they very frequently use CVVH for CRRT. And I think this is a big mistake nowadays in 2018. This is probably due to the past and the history, but now this mistake should not be done anymore. CRRT, as you know, means continuous renal replacement therapy. IHD means intermittent hemodialysis. CVVH, continuous veno-venous hemofiltration. CVHD, continuous veno-venous hemodialysis. And CVHDF, continuous veno-venous hemodiafiltration. Second advice is please do not oversimplify. I think also in 2018, it's difficult to say that hemodialysis is only an intermittent technique using diffusion, only available for small molecules removal. And hemofiltration is a continuous therapy using convection, and it's good for middle molecular weight molecules. I think this is way too simplistic. As it was said a little bit several times before today, we have to look at the hydraulic permeability of the membrane we use. If you use CVVH in your unit, continuous hemofiltration, I'm pretty sure that you use a membrane with a high hydraulic permeability, with a high water permeability, with a high ultrafiltration coefficient, the KUF, which would be more than 20 ml per hour per millimeter of mercury per meter square. This would be mandatory to get a significant ultrafiltration flow rate without a too high transmembrane pressure. If you use CVVHD, you may be able to use CVVHD with a low flux membrane, with a low water permeability. That would work. But today, I think if you use also CVHD in your unit, probably and most likely you use also a high flux membrane. And if you do so, if you use a high flux membrane with continuous hemodialysis, then you're going to get internal filtration and retrofiltration. What is this? So on this cartoon, you have CVVHD, continuous hemodialysis. So the blood goes from the left to the right, and the dialysate from the right to the left. Here, at the beginning of the membrane, you have high hydrostatic pressure, and as long as you move forward to the filter, you decrease your hydrostatic pressure. So here you have low hydrostatic pressure, and this is the opposite with the dialysate, correct? You have here a high hydrostatic pressure, and as long as you move on here, you're going to get a low hydrostatic pressure here. So because of this, you're going to get some internal filtration, internal convection here, allowing for the removal of middle molecules with internal convection, although you are in continuous hemodialysis, right? And to compensate this internal filtration, you have here retrofiltration. That's why I'm saying that it's too simplistic to say that continuous hemodialysis is only diffusion today. So I would correct a little bit this table with saying that for hemodialysis, you can use it, of course, with intermittent hemodialysis, but also, of course, with continuous hemodialysis. And we do a lot of continuous hemodialysis in my institution. For hemofiltration, of course, it's continuous hemofiltration for, I would say, almost 95% or almost 98% of the sessions. But some people, some teams are assessing intermittent hemofiltration as well. So for hemodialysis, you use diffusion, but plus or minus internal convection, depending on the filter that you use. For hemofiltration, you use convection. And with hemodialysis, of course, it's good for small molecules, that is, as it was said several times today also, plus or minus some medial molecules if you get this internal convection because you use an open membrane. And for hemofiltration, you can remove small and medial molecules. So when you ask yourself which modality I'm going to use for my patient, I think you can translate this question by another question, which could be, what are my goals for this patient with my renal replacement therapy session? These could be your goals. You can try to achieve a significant hemodynamic stability. This is what you may want because you have a patient which is, for example, who is in shock. So you want hemodynamic stability. You want a session with a significant filter lifespan. You want a session with an optimization of your molecular clearances over time. You want a session, the membrane performance should be stable over time. Sometimes you may want to modulate the inflammatory response, and sometimes you may also want to improve, to try to improve other organ dysfunctions beside the kidney dysfunction. So, can all these goals be achieved with your different renal replacement therapy modalities? And I think yes. For the stability, you can discuss if you want intermittent hemodialysis or if you want a continuous therapy. For the significant filter lifespan, of course, you're going to play with your anticoagulation strategy. And I would like to show a few slides about the anticoagulation strategy depending on the continuous hemofiltration versus continuous hemodialysis. For the optimization of the solid clearances, again, we can talk about the difference between CVVH and CVVHD. For the modulation of the inflammatory response, we have now a lot of extracorporeal blood purification modalities on the market. I will not talk about this today because it will be treated in other talks during this Congress. And if you want to improve other organ dysfunctions, you can do it with now this renal replacement therapy associated modalities that Claudio mentioned with the most concept. So let's talk a little bit about hemodynamic stability. So of course we have this debate, intermittent hemodialysis versus CRRT. It's a 20-year-old controversy. You have advantages with IHD, you have advantages with CRRT. With IHD, you avoid the risks associated with continuous anticoagulation, that's true. You can easily deploy intermittent hemodialysis at the bedside. Well, I have added some parentheses here because I think we have to agree that this is also true now with CRRT, with the new user-friendly machines. Intermittent hemodialysis allows the patients to achieve greater mobility. And if we take only the therapy by itself, the machine and the circuit and the membrane, then IHD is cheaper than continuous renal replacement therapy. The advantages of CRRT: greater hemodynamic stability, better control of the volume status, a steady control of electrolyte and acid-base status, a good control of the temperature. CRRT avoids the solid swings and cerebral edema, which is very important if you have a patient with trauma brain injury, and also provides a superior uremic control. So having said that, when you look at the KDIGO guidelines, the international recommendations, they told us to use CRRT and intermittent hemodialysis as complementary therapies, but we should be preferring CRRT in case we have hemodynamically unstable patients, and as I said before, in case we have acute brain injury. So in terms of short-term mortality, there's no difference between intermittent hemodialysis versus CRRT. That was shown several times in the past in the literature. I just displayed here a meta-analysis published a few years ago in Critical Care. No difference between IHD and CRRT in terms of short-term mortality. But now we have a new outcome, like for the last decade, I would say, that is very important. Now we tend to look at renal recovery after severe acute kidney injury. And when you look at the renal recovery after severe AKI, there is a growing evidence that there is an association between the use of CRRT at the during the first days of the ICU stay and a better renal recovery. That was shown 10 years ago by Max Bell and his Swedish team from a large retrospective study reporting that an association again between CRRT used in the ICU and a better renal recovery after severe AKI. A few years later, the Canadian team of Ron Wald reported exactly the same result. Better renal recovery with the use of CRRT in the ICU. And we just reported the same result in a French study, a large retrospective study over 1 million ICU patients over 4 years. And again, there was a slight deleterious effect, an association of deleterious effect with IHD and dialysis dependence. Okay? So, for hemodynamic stability and the possible consequence, CRRT seems to be better than intermittent hemodialysis. Now for the significant filter lifespan that you want to achieve for your session. So of course you're going to choose a correct anticoagulant, and the new anticoagulant that now we've been talking a lot during the last years, it's citrate. It has been shown that citrate provides less bleeding complications in our patients, provides a higher filter lifetime. There's no debate on that. All studies, all the randomized control studies, the old ones, the recent ones, all reports that the use of citrate as compared to heparin give you a higher filter lifetime. And if you get a higher filter lifetime and no anticoagulation problem, then you're going to get less unwanted stops, correct? And if you get less unwanted stops, you're going to optimize your administered dialysis dose. I think it was Ravi who mentioned that a little bit earlier. You know, you prescribe the dialysis dose, but then you get what the real administered dialysis dose. And you want to have your administered dialysis dose as close as your prescribed dose, right? It's like when you prescribe an antibiotic, you want that the patient really receive the dose you prescribe. This is the same with renal replacement therapy. So with citrate, you have this. That's why the KDIGO guidelines, again, the international recommendations, tell us to use citrate as the first line of anticoagulation in our patients. In all patients, in the patients with bleeding risk, of course, you don't want to use heparin in these patients, but also in patients with no bleeding risks, as long as you don't have any citrate contraindication. So what's the problem with citrate? With citrate, you can get some metabolic complications, and some of them are due to the release of sodium because we use trisodic citrate. And if you use trisodic citrate and there's a lot of sodium release, then you may increase your strong ion difference, right? if you increase your sodium, you increase this strong ion difference. And based on the Stewart model, this is going to give you an metabolic alkalosis. On the other hand, if you get citrate accumulation, then you can get metabolic acidosis. You can also get hypernatremia. As you return some calcium at the end of the circuit, you can make some mistakes. You can get hypocalcemia, you can get hypercalcemia, you can also get hypomagnesemia. So you can get metabolic complications with citrate. So my question for you is, how do you limit this risk? What is the best way to avoid the metabolic complications with citrate? Let's be pragmatic. Let's give as little as citrate as possible to our patients. If you give a low amount of citrate, of course, you're going to decrease the risk of metabolic complications. How can you do so? Well, I remind you here that now the machines, they are citrate ready because the pumps work together. You have the citrate pump working with your blood flow pump, and you have your calcium pump working with your effluent pump. So a good way to decrease the amount of citrate that you give to your patient is to work with a low blood flow rate, correct? If I decrease my blood flow rate, I'm going to decrease the amount of citrate I'm going to give to my patient. What is the modality that you can use with a low blood flow rate? Continuous hemodialysis, continuous hemofiltration. I think we said several times today that with continuous hemofiltration, if you decrease too much your blood flow rate, then you're going to be very limited very quickly by the filtration fraction. The filtration fraction is absolutely necessary to calculate the filtration fraction when you use CVH. What is the filtration fraction? Again, it's what you take from the plasma, the ultrafiltrate, from your blood flow. The formula is here. The ultrafiltration flow rate divided by the blood flow. If 100% post-dilution, and if you do some pre-dilution, you have the formula here. Absolutely mandatory to calculate the filtration fraction if you use CVH in your unit. And again, don't go over 25%, 20%, 25%. It's a good filtration fraction. It's interesting to look at this study, the Do-Re-Mi-Fa study, and Marlies, who will be the next speaker, gave me these slides. When you look at the Do-Re-Mi-Fa study, it's a European study looking at the practice across Europe from different experts centers. When you look at the modalities given to the patients, you have intermittent hemodialysis, and then continuous renal replacement therapy with continuous hemofiltration, continuous hemodiafiltration, continuous hemodialysis. Okay. When you look at the anticoagulation given to these patients, you can see the association, like the experts using CVHD were also the ones using citrate. That shows you that when you use CVHD, it's probably easier to implement citrate in your unit. And why? Probably because, again, you can decrease your blood flow, so you can give to your patient not too much citrate. And you can limit the risk of metabolic complications. Again, citrate plus CVHD, you can work with low blood flow rate. So you give a small amount of citrate to your patient. It's diffusion, so you can also, if you increase your diazide flow rate, you can remove a lot of calcium citrate complexes, but you can also do this if you do with CVVH. But by doing this, if you work with the low blood flow rates, with low amount of citrate given to your patient, you can push the limits, the indications of citrate anticoagulation in your ICU. I know some good teams, they never give citrate to their patient when the patient is in shock, when the patient has like a severe patient in the ICU. But usually these patients, we don't want to give heparin. But if you can push the limits of the indications by doing this, then you may be able to use citrate in patients for whom usually citrate is known as contraindicated, like liver dysfunction, shock, hyperlactatemia, and several intoxications. But of course, you can't do this if you're a beginner with citrate. If you know enough about citrate, you may be able to push your limits by being prudent with this protocol. And if you look at the literature, this is confirmed. A lot of papers have reported a safe use of citrate with CVVHD and liver insufficiency, feasible, safely used, low incidence of derangements. So that's what about the anticoagulation strategy. Now let's finish with the optimization of our molecular clearances over time. So this is with CVVH. When you look at the, this is the time and this is the circuit function, the performance of the membrane. You see that, and we said that several times also today, if you, with time, you decrease your membrane performance, and this is correlated with the transmembrane pressure. So why is this? It's because, again, the filtration fraction problem. When you move forward inside the filter, you are going to hemoconcentrate here, and you are going to hemoconcentrate also your proteins, and the proteins with CVH are going to form this protein cake, this polarization layer. This is with CVVH. Of course, it's when it's post-dilution CVVH, this is significant. When it's pre-dilution CVVH, you hemodilute inside the membrane, so you limit this phenomenon. And of course, you don't have this problem with CVVHD. So again, my suggestion is when you use CVVH, which we do sometimes also in our unit, it's mandatory to calculate the filtration fraction when you write the CRRT prescription. This brings me to the difference between clogging and clotting. Again, this formation of this polarization layer, these proteins which are going to block the pores of the membrane, are going to decrease the size of the pores. It's called also colmatage. So this is when blood components accumulate inside the pores of the membrane until they totally block the pores. And if your filtration fraction is too high, this is what you're going to have. The permeability is impaired. This is different from clotting, correct? There is clotting when the clots are large enough to completely block the capillary fiber. Then the circulation is impaired. This is a little bit different. However, when you look at the KDIGO guidelines, nothing about the debate CVVHD versus CVVH. Okay, so you should be able to use both therapies. But again, if you use CVVH, don't forget to calculate the filtration fraction. Regarding the modulation of the inflammatory response, a lot of modalities proposed for sepsis. We will have other opportunities during this Congress to talk about this. When you have this bacterial insult, you know, the body reacts with a double inflammatory response, with a pro-inflammatory component at the very beginning, and then after a few days, an anti-inflammatory component called immunoparalysis. This is due to all these mediators, and a lot of techniques are under investigation. We don't have a lot of robust data with these techniques. And in order to move back to like immunohomeostasis. So we will develop this in other talks during this meeting. improvement of the other organ dysfunctions beside the kidney dysfunction. This is called the most multiple organ support therapy. You know, it's when you associate, you combine a therapy in which you can replace the kidney, you can support the kidney dysfunction and other organ dysfunctions, such as the lung or the heart of the liver. The evidence available in the literature with these techniques, with these modalities, is also very low at this time. My conclusion: the model CVVH convection middle molecule versus CVVHD diffusion small molecules, too simplistic in my view. Hemodynamic stability, we have to provide CRRT to our patients, and the use of CRRT as the initial modality in the ICU seems to be associated with a better renal recovery after severe AKI. Anticoagulation, citrate should be the first line, the first choice for CRRT anticoagulation in most cases. When you use CVHD, the advantage is you can decrease your blood flow, so you can decrease the amount of citrate you give to your patient, and then you limit the risk of complications. The filter performance over time, again, CVH leads to the protein cake because of the issue with the filtration fraction. Don't forget to calculate your filtration fraction when you prescribe CVH. The modulation of the inflammatory response, we're going to talk a little bit later about this during the meeting, and other organ dysfunctions. The current level of evidence of these modalities is low at this time. Thank you very much.